بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا أن هدانا الله. It is my great pleasure and honor to be invited from my role model, Dr. Saad Mahdi, in our first collaboration between MIGA is the big brother of MABIC. Really, it is extraordinary chance for me. Thank you, Dr. Saad. Today, we have an important issue to be discussed, which is our patient safety. Of course, patient safety and satisfaction are our aim in our daily practice.
Now, just so don't have more questions, just to move because of the time pushing for the third star of our anesthesia night, which is beautiful night today. Prof. Dr. Medhat Shalabi. He have an impressive CV, but I don't need to take a long time for about him. He's a member of one of the greatest university in Egypt, Alexandria University. His basic training certification from Alexandria. He got an MBBCH master degree and MD from Alexandria. And he just moved after that, big move to UK, where he completed his training and certification. He got diploma of anesthesia from UK, fellowship of Royal College of Anesthesia, FRCA. His current boss now, just coming to last moment for me, that's a consultant in Cleveland Clinic, London. Now in Basildon University, is this right like this, Dr. Medhat? Hospital. Dr. Medhat have a very long experience in anesthesia. Also have a long experience as a speaker in national and international conference. He's what's called normal guest for most of the conference, and I saw many of his presentation. I like it. Prof. Medhat Shalabi is the founder and the president of Pan Arab and Middle East Enhanced Recovery After Surgery Society. He's also vice president of World Society of Venous Anesthesia. At the end, Prof. Shalabi have activity everywhere in national, international, and he's a regular guest, as we see, a speaker in national and international conference. Dr. Medhat now we are just about to take off, and the lead for you, Dr. Medhat. Can start your presentation.
I would like to thank you very much, Professor Yasser, for this huge introduction. At the end of the day, I am an anesthetist who have passion for his patients. That's who I am, and I think that can explain everything I do. I love my patients, and I would like to give my patients the best. Every patient should receive the best of our abilities. Today, I decided to talk about medication errors because we are talking about patient safety, and this is an ongoing problem. So is it, how can I change the slides? Oops. Can you see the screen?
Yes, Prof. Medhat, we can. Yes, we can.
The screen is okay. So how can I change now? Because I'm trying to change. Now it's okay. So this medication error, contrary to what we expect, is on the rise, not on the, I wanted to minimize this. Yes, okay. Yeah, so medication error is on the rise rather than going less and less. And today, one of after John talk, one of the audience from India mentioned about giving a wrong drug, spinal, which reminded me that when I was a resident or when I was an assistant lecturer, and there were two cases in around Alexandria about giving the wrong drug in a spinal, the same, and the two patients died as well. So you can see that things are keep repeating themselves. This, I was assistant lecturer maybe 30 years ago, and here again, the same problem is happening again. So this should alert us that the problem is still going on. So first, I would like to define adverse drug event. Adverse drug event is an injury resulting from medical intervention related to a drug. This includes medication errors, which I will talk about, adverse drug reactions, which is different, and allergic reactions and overdoses, so wrong doses. An adverse drug event can also be defined as harm caused by the inappropriate use of the drug. Medication errors are any preventable events that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professionals, the patient, or consumer. Such events may be related to professional practice, healthcare products, procedures, and systems, including, and this is important, prescribing, order communication, product labeling, packaging, nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. So you can see that there are so many places where an error can happen. And this was published that global trigger tool shows that adverse events in hospitals may be 10 times greater than previously measured. So we usually underestimate and underreport that. We found that adverse event detection methods commonly used to track patient safety in the United States today, voluntary reporting and the Agency for Healthcare and Research and the Quality Patient Safety Indicators fared very poorly compared to other methods and missed 90% of the adverse events, 90%. The Institute of Healthcare Improvements Global Trigger Tool found at least 10 times more confirmed serious events than those other methods which happened. So again, the problem is bigger and bigger than what we think. And this is happening in a highly reliable industries. Medicine is very highly, should be very highly reliable because any mistake costs life, like aviation, like transport, like, so these should be fail-safe to a great extent. And we always remember the look-alike and sound-alike drugs. And this is this example, which I just mentioned and was mentioned by our colleague from India, is the same. The ampoule of bupivacaine was similar to what was given, tranexamic acid, I think. And it was given by mistake because they look after each other. And I remember very well that the discussion at that time, which is not happening these days, thank God. At that time, I remember that the discussions happened about how this tranexamic acid caused death for the patient being injected in the spine rather than intravenous. And everybody went into analyzing what was the mechanism of leading to death. And it's important, yes, to know the mechanism which lead to death, but it's far more important to avoid giving a drug in a different place than it should be. And this again, I would like to say that very clearly, cost nothing. I remember every time I go back from the UK to Egypt to give a lecture in the Egyptian society, they always ask about giving lecture about what is very new, what is the most updated. And all my life I wanted, and this happened, I remember very well, after the case of the actress who died, then there was a very important discussions in the newspapers about safety. And then it was my chance to give a lecture about safety in anesthesia. And I promised them that all the lecture I will give was things that cost nothing. Like, again, checking the drugs, checking with another one, and reading and confirming, etc., which are all like airway assessment. It costs nothing. It's at bedside, as John described, and it's free. So it is not always very expensive to do the right thing. The Joint Commission Sentinel Patient Harm Adverse Events found that the main reasons, as you can see here, the human factor, the leadership, which was very nicely explained by Professor Magdi Khalil lecture, and the communication. So these are very important causes and still contributing to great extent to our adverse events and drug errors. And Magdi explained that when we design something, we should design it right, not to do this. You know, this is a pathway for the disabled, and then they have done this, or they have done this, or they have done this, and then they put this. So failure to plan, as Magdi very nicely explained, is in a way leading to failure, is planning for failure, actually. So when we design and they try to rely on the technology to have something, a gadget which help us and help, should be designed in this way. Because if an error is possible, someone someday will make it. So the designer must assume that all possible errors will occur, and the design so as to minimize the chance of the error in the first place, or its effect once it gets made. So this is very important to remember. We should make things feel safe. And the human factor, I'm sure Professor John Doyle have explained it in a great way. So again, I will skip this human factor approach, and we'll see here that when we do the fishbone for the diagram for medication error, we'll see that there is a human factor, drug unfamiliarity, drug unfamiliarity, patient unfamiliarity, like we don't know that he's allergic to this, human factors, data disregarded, inadequate data, and then machines like infusion pumps can fail, methods like the protocols and training, which Magdi very nicely highlighted, production pressure, standardization, labels and cards and handoffs, incomplete or illegible labeling as well, and the materials as well, drug shortage, limited concentrations, double dilution, limited solution sizes, 100 mils bags, limited supply of labels, look-alike, sound-alike. So all this can contribute to drug error. And I will give you a very good example. It's not good because it happened to me, but it's a very real example of how can you do drug errors. I am trained in the UK. I know what to do in drugs, and I review and I do everything. But I've been practicing in the last 14 years in Dubai, and I went back to the UK. And one of the lists, first, I usually myself don't give antibiotics except in 50 or 100 ml bags. I don't like to give boluses of antibiotics. So in the hospital I was working in, they don't have 50 ml bags or 100 ml bags by chance. So I was obliged to use the antibiotic prophylaxis in 20 mils, and I give it very slowly because sometimes they cause nausea to the patient. And one of the doctors, one of the surgeons, requested another antibiotic than what we used to. And I'm not very familiar with that, but I have the ODP with me who went and brought me the new drug, and he brought me 20 ml syringe and the dilute. So at that time, it was a big mistake from me that I didn't imagine it should be diluted. Of course, I should have read, but this is a situation like can lead to an error. And I diluted the drug in 20 mils and I give it to the patient, and the patient suffered a little bit, but there was no harm whatsoever. He at that time felt pain and felt flushing, but after that he was absolutely right. But again, this is an example that human errors still can happen, whatever we are. So we have to look into these things and learn from our mistakes and report, which I have done. So I don't think it will happen again with me at all. And these are medication errors. There are errors in prescribing. And the failure mode here is inadequate knowledge and information. And the intervention is to have practice guidelines for labeling and the preparation, expectation, syringe size, dilution, dose, calculator, etc. Prepare in preparation, so dilution error. Sometimes now we have the pre-filled syringes. So I have now pre-filled syringes for phenylephrine, pre-filled syringe for ephedrine, pre-filled syringes for adrenaline, epinephrine, etc., etc. The labeling, we should look at that because sometimes even the labeling can be error. So we standardize the color codes everywhere and we try that. I hope it's present everywhere. The vial swab, medication tray standardization. I'm not sure that this is happening everywhere. Now I am practicing in the UK and I don't see like 100% compliance with the medication tray standardization. Anesthesia cart top standardization for syringe swab. So there are lots and lots of things. And you can see here, there are standardizations, there are technologies, and there are pharmacy, pre-filled and pre-mixed, and culture. So all these, you can take this because it's again very important to revise all these, and I don't want to go to, for the sake of time, you can copy it and look at it, but these are all ways, consensus recommendations to avoid drug errors in the operating room. Again, we should know what is mindful versus mindlessness. To be mindful, and this is important for all of us, and this will cost us nothing. To be mindful is to have a rich awareness of discriminatory detail and an enhanced ability to discover and correct errors that could escalate into a crisis. So Professor Magdi Khalil, when he explained that if you blame someone and do ABC, to blame and criticize and accuse is totally wrong. We are in a no-blame culture, and this should be the way forward, that everybody will volunteer then to report because it's anonymous. Mindfulness and safety, so we should be preoccupied regarding small, insequential errors as a symptom that something is wrong, and finding the half event. Important. Sensitivity to operations. We should pay attention to what's happening on the front line at the shop floor. Reluctance to simplify. We should encourage diversity in experience, perspective, and opinion. We should have commitment to resilience. We should develop capability to detect, contain, and bounce back from events that do occur, and they will continue to occur. We should have deference to expertise. We should push decision-making down to the person with the most related knowledge and expertise. So again, this was, I think, mentioned. There are skill-based actions and rule-based actions. Skill-based actions become subconscious and automatic schemata. We come to the autopilot role by training and training and training, and then we need to avoid slips and lapses and fumbles. Role-based actions, nearly subconscious, to use the wrong rule or use the right rule at the wrong time. Knowledge-based actions, the lack of knowledge-based actions, consciousness, slow, laborious, figure it out, take a guess, use a part of other rules, or guess wrong. Violations is active decision to not follow the guidelines, policies, procedures, and best practices, and normalization of deviance. So medication process, first we need to diagnose, choosing the medication, decision support, pharmacy. And there are machines which help us for that. Ordering, decision support again with the pharmacy. And the new machines like Omnicell or Pyxis system, they all help in that. And this was a discussions, but none of them can replace the human factor and acting on the human factor. Dispensing and preparing, two-person check, very important. This will cost nothing. Administration, barcode administration, again, two-person check is extremely important. Documentation, automatic documentation, because the systems like the Omnicell and the Pyxis will be automatically documenting, and monitoring by the pharmacy, and decision support and the lab. Medication errors in anesthesia, such as substitution, syringe, or vial swab. Exactly like instead of Marcaine or Bupivacaine, we use the cyclocarbon or the tranexamic acid. Omission is redose the antibiotic or failure to act. Wrong dose, it can happen. Repetition and insertion, it can happen as well. Wrong route, as we mentioned, we put intraspinal, something which should be intravenous. Wrong timing, wrong rate and inadvertent boluses, documentation error, monitoring error, and labeling error. So we can see in anesthesia, we are confronted by huge amount which we can err in, and we are human. The teamwork failure as well can contribute to that. The communication between the surgeon or handoff relief versus terminal, and hand off tobacco or to ICU, hand off to relief, like as Professor explained, that sometimes you go for coffee or you go for lunch and one of your colleagues, so you must give him a very reliable handoff for the patient. Situational awareness, surgeons can inject sometimes, so you need to communicate very well with the surgeon, or perfusion injections if there is a perfusion. Distractions and disruptions contribute to skill-based error. Distractions are sometimes happening in theater. So error prevention strategies. Number one, which is the most important, is the individual level. So there are skill-based error, which we should stop, think, act, and review in order to give anything. Reduce distractions and interruptions. When you are giving drug, it's a time you should concentrate very clearly on giving the drug. You shouldn't be distracted by doing anything else. This is very important. And then rule-based, think a second time and ask for a second opinion when there is a chance or there is need. Communication, you should be aware of the situation you are in. Handoff protocol, there should be protocols for that, for relief at the end of the operation or at the end of your shift, in handing over to the PACO or the ICU. Very important. Speak back. You say things and they repeat to you. Read back. Three-way communication. All these cost nothing and extremely, extremely important. Standardization, same medication trays in all anesthesia locations. This should be in every hospital. So every hospital should have this medication trays in this special arrangement for everyone working there. Standard cart top setup, unique box for unique medications, single concentration for all infusions and cocktails. Technology like barcode administration, automated labels, smart pumps, libraries, Bluetooth connectivity, decision support, the Omnicell, and as we mentioned before, they are very helpful, but they will never avoid. They are designed to avoid some of the human errors, but still awareness and human factor and the concentration and avoiding distractions is extremely important. Do not distract me. We should be in a distraction-free zones and the quiet areas. Sterile cockpit in response to a number of distraction-related air disasters. The Federal Aviation Authority enacted the sterile cockpit where crews must refrain from all non-essential conversation to minimize unnecessary distractions during all critical phases and under 10,000 feet. A similar silent theater procedure has been adopted in some operating theaters to minimize distractions during the critical phase of a surgical operation. What about music? In aviation, no music is allowed. No non-domain specific materials such as books, newspapers, videos, etc. are allowed during flights. But how many mobile phones are allowed and things like that? We should think a little bit about that. At least during critical times, at least during injection of a drug, at least during the timings where errors can be really dangerous. Other error prevention strategies: pharmacy, pre-filled syringes, pre-mixed stuff, clinical pharmacist in OR, satellite pharmacy. Pharmacy controls all aspects of medication chain, commercial pharmacy pre-mixed. culture, just culture. Safety in reporting errors. And it should be, as Professor Magdi mentioned, it should be no accusation, no criticism, no blame, in order to encourage everyone to self-report any errors, to avoid them in the future. Personal and system accountability and respect to each other and to the patient and to our profession. Unique location for unique medications, hypertonic saline, local anesthetics, concentrated medicines such as heparin and insulin, which were mentioned, concentrated potassium. This should be located in unique locations to avoid any problems with them. Wrong route, small bore connectors, and this is happening now in many hospitals. I don't know everywhere or not, but now you cannot inject intraspinal anything except from a syringe that is designed for intraspinal, on-fit and NR-fit. And of course, asepsis should be there. The problem with anesthesia medication safety is that anesthesiologists are the only physicians who prescribe, dispense, then administer the drug to the patient with no review by pharmacist, nurse, or patient. And this is a huge responsibility on our behalf. There is simply no check or verification. So when you do that, you should respect that, and you should be fully aware that any problem can be fatal, and you don't want that. And the challenges in anesthesia medication safety can lead to lawsuits and problems such as that. The ASA claims project data 2008, 6,000, nearly 7,000 claims, 44% incorrect dose, 40% wrong dose, 8% timing of dose error. Drug errors are happening, and payment up to 230,000 versus 140,000. Barrier to reporting adverse effect, again, they are very important to know, and I don't want to go into them. You can take the table for yourself to use it, because for the report of time. So safety 1 and safety 2 thinking. Safety 1, reduce number of adverse events. Focus is on what goes wrong. Look for failures and malfunctions. Try to eliminate causes and improve barriers. Safety and the core business compete for resources. Learning only uses a fraction of the data available. On the other hand, safety 2, ability to succeed under varying conditions. Focus is on what goes right. Use that to understand everyday performance, to do better and to be safer. Safety and the core business help each other. Learning uses most of the data available. So in medication safety, there is currently no coordinated national database to track anesthesia medication errors. Multiple reporting systems exist throughout the world. Most reporting still relies on voluntary reporting. Many reporting databases are complex, difficult to use, and time-consuming. Research efforts underfunded with dissimilar methodology. Anesthesia providers, which are us, still do not believe they actually make as many errors as has been shown. I don't think we are very aware of that. Challenges in anesthesia medication safety. Anesthesia medication handling needs a new vision. The anesthesia approach to medication error is primitive, fragmented, and cavalier. While several studies have tried to define the true incidence of medication errors in anesthesia, there is still some question as to the actual incidence that really exists. Strategies to reduce, again, we went into them. I don't want to. Human factors contributing to mishaps, normalization of deviance, poor communication, production pressure, fatigue and stress, emergency operation, inadequate provider experience, inadequate familiarity with the equipment, device, surgical procedure, anesthesia technique, lack of skilled assistance or supervision, afferent overload, normalcy bias, assuming alarms are false alarms because we hear them a lot, faulty to absent policy and procedures. In summary, new view of human error. We should have this. Events are the results of many causes. Active failures and latent conditions create holes in our system's defenses. We haven't fully understand an event if we don't see the actions as reasonable. The point of human error investigation is to understand why people did what they did, not to judge them for what they did not do. I think we heard it quite a lot today. Root cause are causes with potential for redesign to reduce risk. Active failures are rarely root causes. Latent conditions, on the other hand, are often root causes. Getting inside the tunnel will help us understand why events occur. Medication administration errors in the ORs come from individual and teamwork failure. Technology and the non-technology solutions exist and are effective. All system defenses rest on individual choices. Violations abound. So the journey to zero rely on process design, reliability culture, and the human factors integration together. And effectiveness, not by warning and the alerts and the accusation, but we come up by education, policies, checklists, reminders, standardization, automation, and forcing functions. These are much more effective as we go up. No matter how well equipment is designed, no matter how sensible regulations are, no matter how much humans can excel in their performance, they can never be better than the system that binds them together. Ladies and gentlemen, thank you very much for being such a great audience. Thank you.
Thank you, Prof. Medhat. Really, I have a couple of questions in my brain, but you answer all the questions, and thank you for that. But I have, I have two events happen in our hospital, and I need just to ask you, how can we proceed with the investigation in these hospitals? I think many times, just we prescribe levobupivacaine for infusion for BCA post-operatively, and the patient move and he turned back, so the nurse connected.
Epidural, you mean epidural?
Yes, epidural, bupivacaine.
Yes.
And the patient going to bathroom and he returned back, and the nurse connected to the IV. And they call us, tell us the patient is hypotensive, and he was taking for 2 days. But I ask about our role in that. The second event, that the patient 19 years old, we teach him how to use a BCA after orthopedic surgery, and his dad came to sit down beside him, and he holds the button and still squeezing until the patient arrested and resuscitated. At last moment saturation was 94, but the carbon dioxide 120. So this happened outside our location, but I think you are engaged. How can you solve this issue? How can correct this issue?
Number one, for giving in the wrong location, Now, as I told you, there are non-interchangeable. You cannot connect an IV to something which is epidural. So this can prevent and make it fail-safe device. You cannot connect the nurse, even if she wants to connect by mistake the intravenous, she cannot connect it to the epidural, or vice versa. About the father who is pushing the PCA, #1 rule everywhere in the world, it's only by the patient. This is the inherited safety of it. So if a father did it, I don't know, was he explained clearly to everyone how old was the child or the patient?
19 years old, 19.
19. So he's not a
You
child.
teach him how to use it.
How can he did that?
I'm asked about how can we proceed? We have a role in that, or are blamed for legal issue, or how can we prevent that?
If you explained clearly and the consent is clear and he's 19 years old, I don't think you have, if you explain everything very, very clearly and everything is documented, I don't think you will have a problem about that, because this is your responsibility comes in explaining and making sure, and sure the nurse has explained when she gave the PCA and told the patient, they tell him nobody else is allowed to touch the button.
Dr. Yasser, I think I've got a little comment on this. I think, you know, the main issue here is how do we prevent something like this? And preventing something like this, we do have a role as anesthetists, of course. We all put protocols and guidance for how to use the PCA in a room, but equally, we are responsible for putting the protocols for monitoring, and monitoring by the nurse will be a shared responsibility. To put a protocol for this will be the anesthetist and the nursing staff putting a protocol for monitoring the PCA or NCA. We do have nurse controlled analgesia as well. And if that protocol is tight enough, hopefully this could be picked up early in advance. You know, respiratory rate, saturation, need for oxygen, all this could have been picked early in advance. And of course, a patient on PCA should be put in a place where, I'm not saying critical care or anything, the ward need to, you know, they will have 2 or 3 PCAs happening at the same time. They will have more vigilant observations and more vigilant, because for somebody to be left all that, it's just a little bit, you know, it could have been avoided. The other one, even when you said they have been having IV local anesthetic for 2 days or for some days, I think again it goes to the monitoring and what needs to be instituted in the monitoring. Part of the checks would be, is this going in the right, connected to the right thing? Like the pump is going, yeah, the pump is not alarming, but still pressures are okay. The rate is still okay. It's going in the right place. And part of the checks is to check that it's actually still attached to the right place. And with handover between nurses, every time we do a shift or a handover, the nurse coming will need to check all this and making sure it's going in the right place. So we do have a role actually putting these protocols all together to mitigate and minimize the drug errors. Drug errors are going to happen, of course, but I feel that we do have a role here. And provided that this is being done, then it's a system error and somebody probably didn't have a look at whatever, but this is our role and we need to discharge our liability that way.
Thank you, Dr. Thank you. I have a question here, but I don't understand, because Dr. Basma just write log the dose for BCA. I don't understand. What is log the dose for BCA?
Sorry.
You know,
For patient control, like a maximum dose.
Yeah,
she means we
lock the dose, lock the dose. You make the lock out intervals.
No, to be honest, we don't put normally we don't put a maximum dose because the inherited safety is to allow the 5 minutes and the patient pressure. So if the patient, so this is like the most important part of the PCA, that it should only be operated by the patient. Nobody else should touch this. So this is like, I was in the UK when we started the PCA, and that was #1 rule.
I think what the question is about, if we have a look, if we have a lookout time on the PCA 5 minutes or 6 minutes, there is an assumption that even if we keep pressing it, then you're not going to overdose. I think this is what she's trying to say, and I can understand where she's coming from. What's the point of having a lookout time when this lookout time is not going?
I'm sorry, Mu'taz.
It's not going to lead to. This is what she means. No, I'm trying to explain the question, Medhat. I'm not
saying
saying
but
this is the case.
The lookout time is not designed for the purpose of if somebody else, like the father or a friend, pushing, because you can push and give every 5 minutes, but every 5 minutes can be lethal.
No.
The inherited safety.
Let's clarify this. Let's clarify this. If you keep pressing every 5 minutes, the calculated dose, if you keep pressing it every 5 minutes, there is a leeway of safety, and that's where I said if the patient is monitored adequately, that leeway of safety can mean that you can actually rescue the patient before they go where they have massive respiratory depression, because they will end up having respiratory depression. We agree about this, but the lookout time, the message to whoever is asked the question, that the lookout time does not prevent toxicity or overdose. It will give you time, it will buy some time for the patient not to reach a toxic dose. But if they keep pressing it unnecessary, because it's built on demand, which means every patient is different. Somebody's going to lose the respiratory drive at 2 or 3 or whatever it is. So this gives you a little bit of a leeway of safety and gives you a bit of time, but it won't actually be proof to respiratory depression. They will still get respiratory depression, but after a bit of a longer time, and that's the reason for the lookout time. But it does not protect the patient. That's the message. It
doesn't.
I think the solution, I was in one of the Wills hospital at that time. So first thing we did, as Dr. Medhat said, we make an epidural, just can't connect it for IV, the connection suitable for that. And again, after this event, we change all the BCA machine in the hospital. The BCA will come with a nasal cannula with 2 liters of oxygen, and at the same time, they measure the carbon dioxide. We adjusted for example, if the saturation coming down 94 or less, the machine will not give, even it's eligible to give. Again, if the carbon dioxide, for example, coming to 45 or 50, whatever, the machine will not give, even if you want to give, and they have a eligible amount of doses. And this is solves the problem. But the main issue, as I said, we're thinking about our role in preventing that, our role to teach the nurse, our role, legal role. And thank you for your answering, Dr. Mu'taz and Dr. Medhat. It's a very great discussion with us. And also, before to leave, I have Dr. Abasma thanking all the people here. And now I don't have more question here. So now I will endorse for Dr. Safa to make an,
can I comment? Khalid, he mentioned Khalid Balah. How are you, Khalid? هو بيقول برضو إن ال PCA pumps, there are 2 safety measures. First, the lookout interval, and second, the maximum dose per hour. Normally, I don't, for example, prescribe any maximum dose per hour. But all I am relying on is that this will be operated upon only by the patient. That's the most important, because when you put a maximum dose per hour, you take out the variability in our need for the analgesia, which is like 10, 20 times different between me and somebody else.
Yes.
So if the patient is the only one pressing, the safety is there. And we shouldn't go about this for a long time, because it's simply operated only by the patient. That's it. Or the nurse, if nurse operated, a nurse controlled for a pediatric patient, after she will ask the patient about the pain, etc., etc. So when we do this in the right way, you will never have a problem with overdosing. And you shouldn't, or you don't have to have a maximum dose per hour. But if we have somebody who is going to press for the patient, this is like killing the patient. That's totally shouldn't happen.
Can I just put a small little comment? There is an inherent maximum dose anyway, because if you say
5 minutes multiplied,
5 minutes, and you give 1 milligram, so you know, it's 12
milligrams per hour. But I will tell you something, Mu'taz.
It is an inherent,
even this
dose, but this maximum dose is big. It is big. Yeah,
it is there, yes. But you know, as you know, I'm sure you know that we were never called because the patient is over sedated with PCA. It was always, we are called because the 12 milligrams were not enough. So we come to override this and give the patient more.
Yeah.
Never because it is too much. It's always because it's too little.
Yeah. Thank you for the speaker, the moderator, our colleague, our professor. Thank you, Dr. Magdi, Prof. Doyle, Prof. Medhat. Thank you, Dr. Saad. Thank you, Dr. Mu'taz. I'm just happy to be with you and Dr. Safa. And now I will endorse Dr. Safa just to make a comment and last word in this session. Thank you very much.
Okay.
Dr. Safa.
Really, it was an excellent webinar. We discussed a very hot and challenging issue about patient safety. Many thanks for Prof. John Doyle for his fascinating lecture. Highly appreciating your presence today with us. I'm so honored to learn more and more from you, Professor John. Thank you. My thanks and regards expand to my great professor, Dr. Magdi Khalil, my professor in Menofia University, for his valuable information today. Also, I appreciate and respect the presence of Professor Medhat Shalabi this night and his elegant support for MEGA for many times. My special thanks expanded to my elegant friend, Dr. Saad, who allowed me and the great moderator, my colleagues and my friends, Mu'taz and Yasser, to be here in this sweet November night. I wish all the best for all the panelists and attendees. Thank you for you all till meeting again in the next webinar. All the best luck and best wishes. Good night. Have a good night.
Thank you.